Hello everybody, good evening. So it's my great pleasure to introduce this evening Manoj Sivan, who is a clinical professor and honorary NHS consultant in physical and rehab medicine up in Leeds. He's a past president and current research chair of the BSPRM. I think it's fair to say that his influence has been and continues to be tremendous for our specialty and for rehab in general. So he ranks 135th in the field of rehabilitation, which puts him in the top 0.5% of researchers worldwide. He's got over 250 peer-reviewed publications with more than 8,000 citations. He's secured more than £10 million in research funding over his career so far. And through his international work and collaborations, I think it's fair to say that he's given UK rehab a presence on the global stage. So we're very fortunate. Manoj is going to come and talk to us now about his work on dysautonomia and rehab. So over to you, Manoj.
Thank you so much, Sarah, for that introduction. I think it was worthwhile coming all the way here for that introduction. Okay, thank you. So maybe you just want to find out who's in the audience. Medics, physios, occupational therapists. Great, and who else is left? Any scientists, basic science? And we do have an autonomic unit in UCL. Anyone from that unit? No? Okay. Great. Okay, so I mean, my aim actually, when Sarah invited me, was to actually visit the unit because I worked with Chris Matthias and then, you know, the people who are currently there. So I thought, well, it'll be good to sort of visit the autonomic unit and then do this talk. But then at the same time, I got pulled into an NIHR meeting in RCP, so I've just come from there. So that's good. So I'll have to make another trip to visit the autonomic unit. Great. I mean, what's the staffing like in the autonomic unit? Any idea?
I'm trying to remember. They've obviously got two consultants. Yeah, I don't know. There's like a handful of clinician scientists, clinical scientists as well.
Great, fantastic. Okay, so what I'm going to do is the sort of the disclaimer here is, you know, I am pre-COVID. I wasn't an expert in this area. I must admit that my research was more around robotics, upper limb after stroke. Then I went into alpha entrainment in chronic pain. And then the pandemic happened. And then obviously all of us as clinical academics, we were sort of redeployed to NHS, managing patients in the front line. And then I got into what is now called long COVID, so looking at persistent symptoms after the COVID infection. And then we had a huge NIHR grant, and that led to something else. And currently I'm doing another research grant with NIHR called Heritage. That'll keep me sort of in this field for another 2 to 3 years. So what I'm trying to say there is, you know, I am new to this field, but I'm kind of completely now sucked into this field, and this is going to be my future. So, you know, whether I like it or not, this is going to be my field of research. So what I'm going to do is I'm going to obviously talk about post-infection conditions, which is long COVID, and then you have the ME/CFS, and you've got other conditions. But maybe, you know, I'll try to bring in other conditions as well, because as we know, autonomic nervous system is quite key actually in sort of work we do with brain injury patients, with stroke patients, with chronic pain patients. So hopefully, you know, if you all do not see patients with long COVID and ME/CFS, there will be something which you can draw in from this talk and maybe apply to your field, whether it is stroke rehab or TBI rehab or pain rehab, because I think it's quite critical, isn't it? You have an autonomic nervous system. How come we don't do much research in this area and you know, study the area more? Because I think it is very critical, the link between autonomic nervous system and fatigue. And we all know from the patients we manage that chronic fatigue is one of the top symptoms, isn't it? It's definitely one of the top 5. Any patient group we manage in neuro rehab, fatigue is right up there. So how is it that we are not actually researching more into the autonomic nervous system? Because the link is very clear, and hopefully I'll try to demonstrate that link and some of the work we've been doing on, well, how do you test for dysautonomia? Because it's quite subjective. Are there any objective tests? And not everyone can have tilt table testing because it's quite specialized and the volume of patients we see is very difficult. So I'll touch upon that. And that would be quite interesting, I think, for this audience as well. Can we do those simple objective tests in our clinical setting? And I think that could be quite a good thing for you to take away from this talk. So Sarah's done all the introduction, so I can skip through all my affiliations there. And yeah, just talk a little bit about, it's quite important to understand that there are about 3 million people currently struggling with chronic fatigue. So if you just include long COVID, ME/CFS, that is around 3 million. So the burden is huge. I have got healthcare professionals in my trust, leading healthcare professionals, leading consultants, currently made redundant in the NHS. So there's more than 50 of them in a single trust who actually lost their jobs because of long COVID. And still there is this stigma and disbelief about the condition. And so it's a huge mismatch because there's a lack of research, lack of proper research to understand what's going on and how do we address this condition. So we all talk about Florence Nightingale and the Crimean War and all the work she did. But actually, I don't know how many of us actually realize that when she came back from the war, for the rest of her life, she was actually bedbound with it was not post-viral, it was she got brucellosis, so it's a post-infectious condition with chronic fatigue. She was literally bedbound for, I think, about 20 odd years. And all the work she did in terms of hospital hygiene and all the papers she wrote actually was from the bed. That is actually a model diagram. That's not an actual one, but that is her life. And I think we don't talk about that much, So it is that sort of debilitating, but it also is a positive aspect of the story is, these people can still be functional and achieve great things. And the same applies to Charles Darwin, and he has had problems with unexplained illness for most of his life, around 40 to 50 years, he's had non-specific symptoms, GI symptoms, chronic fatigue. He'll do, obviously all the great work he did, but he used to pace himself. So he used to do a little bit and then he'll have a crash and then he'll be, resting for the rest of the day. So again, it's still debated what was that illness and nobody has an answer. And now people are saying, well, looking at the symptoms, it was probably chronic fatigue syndrome. So with that, I thought, we will talk about those things which I mentioned. I'll talk about mostly the kind of work I have done, to be honest. It's such a huge area, and I'm not here to, give you a summary of the whole literature. I know that'll be more useful, I think, for you, but it'll be more difficult for me. For me, it'll be much easier to present the work I've done in the last 5 years. And we can talk about things, and if you have ideas, I think we should make it more interactive. There's no point waiting till the end because we've got 1 hour to fill. So feel free, just raise your hands, and then we can take a question as we go along and have a debate. Is that okay? Yes. Okay. Right. So so fatigue is, that is the definition. We very much sort of appreciate that in our patient group. And if you just look at general population, it's about 20%. And if you're looking at chronic conditions, the conditions we manage, it's way higher than that. It's more than 50%. In conditions like, for example, rheumatoid arthritis is 80%. In TBI, it's about 60%. So we don't need to go into that. It's definitely more than 20%, which is seen in the general population. So, again, chronic fatigue is a talk on its own, and I thought this actually is quite a good summary in terms of what are the different things one need to sort of look into when assessing a patient with fatigue. So obviously there is patient factors, and the comorbid conditions, which is primary. I think that is very essential, and we cover that. We understand the patient's premorbid conditions and other factors. If the patient has had a long hospital stay, there is going to be physical deconditioning and muscle weakness, so we can understand that as a cause of fatigue. And then obviously they've not been they've just been in hospital beds, a lot of muscle wasting going on, so your energy balance is affected. And this is huge, isn't it? We all know that your autonomic nervous system is controlled centrally, and you have all these cognitive factors which actually are related to fatigue. If the patient has comorbid anxiety, depression, cognitive impairment, sleep quality, it all affects and your energy levels, and it is going to make you feel fatigued. There's a big area of research around inflammation. So people have looked like conditions like rheumatoid arthritis. They've looked at all the cytokines and how that is related to fatigue levels. So that is well researched. And obviously we know very well that, the HPA axis and alterations in levels, the cortisol levels is linked to your energy levels as well. So we are interested in this. I think it's under-researched actually, even though it is actually as important as anything else in fatigue. I think this area is often overlooked, primarily because I think we are not trained very well in autonomic nervous system. And I had no idea about autonomic nervous system prior to entering the field of long COVID. I'm being very honest about it. Yes, we all learned about it in medical school, but then when we were searching for answers for what's causing these persistent symptoms, and that's where actually I came across and started understanding more about the autonomic nervous system. So I think it's badly taught at med school or other professions, and I think we do not actually give much importance to the autonomic nervous system. You can use this as well, isn't it? Okay, I'll use this one. Okay, so this is a good paper I was looking at, which actually illustrates the point I was trying to make, that these are the various studies which have looked at not only cancer, but they've looked at MS, they've looked at COPD and chronic kidney disease, rheumatoid arthritis, predominantly focused on the inflammation. How is that related? How the cytokine levels are related to fatigue. And then some papers have looked at the HPA axis, but look at the kind of absolute dearth in kind of the autonomic nervous system function. Hardly any papers have looked at it. Okay, so there is a clear, as we said, even in research, there is a lack of understanding of how your autonomic nervous system is linked to fatigue. Now, we all know that they are linked, they are interlinked. Inflammation is linked to your HPA axis, is linked to your central nervous system, is linked to your ANS. So it's a inflammatory autonomic nervous system. So we understand that they are all linked. However, we seem to be more interested in studying what is obvious, which is what is measurable in a blood test, rather than something which needs a slightly different sort of testing rather than a blood test. Okay, so then I'm going to introduce a new concept now called PEM or PESE or a crash. Now, how many people understand this phenomenon? Hands up. Okay, so half of you. So that's very good. And I think this is what is very critical in understanding chronic fatigue and its link to the autonomic nervous system, because there is a phenomenon called PEM or PESE. Now, I mean, you can read all that. This is the CDC criteria, and they make it very specific that you need to have that abnormal response to a minimal amount of exertion, whether it's physical, cognitive, or emotional. You need to have that exaggerated response to that minimal stress, and that should take such a long time to recover. So the recovery could be hours, days, or even longer. So the patient, and actually the onset can be delayed as well. So the patient will give you a typical history that, well, they've overdone something today, but then the following day they completely don't have any energy. They are, the battery is completely run out, and they're going to be in that state for days or longer. And I think that is defined as, there's lots of terms there. In patient terms, it's called the crash or the flare-up. but then PEM, or now actually this is a latest terminology we are pushing for, that it needs to be called PESE, because it's just not the malaise, it is actually all the symptoms get exaggerated, post-exertional symptom exacerbation. So it's quite critical when you're taking a fatigue history, that obviously you're asking them, okay, when do you feel tired, etc., but do you get crash? And then you define that to the patient, that when you exert yourself on a certain day, the following day, are you getting this kind of complete lack of energy, and where you're taking long to recover? And I think that is critical because of the link to the autonomic nervous system. Now that again, this is something which needs to be proven, but this is what is our thinking, that this is where the autonomic nervous system comes in, that if a patient has got PESE, then they have got dysautonomia. Now, there are various theories to it. People have linked mitochondrial function to it, and they think that, in all these disorders, there is mitochondrial fragmentation, and that is linked to your autonomic nervous system. And that's when you exert yourself, you're running out of ATP, and then you're switching on to your anaerobic glycolysis, you're generating more lactate, and that is what is causing the crash. But, that's not fully proven. But what is clear, now again, that needs more research, is that clear link between autonomic nervous system and the crash. So what we are saying is, when you're seeing a patient with chronic fatigue, do ask for this history, and when this history is there, then start thinking about autonomic nervous system and how you're going to investigate it. These are the different kind of stressors for patients who report crashes. So it's just not only physical, it's also cognitive, and people like, I was talking about all these healthcare professionals, they're not doing physical work, but for them it's the cognitive demand. I'm talking about A&E consultants, I'm talking about cardiologists, I'm talking about respiratory physicians. It's quite cognitively tasking for them to actually manage patients, do the ward round, and they give this typical history that 1 hour of work, what they used to do, and they are finished for the rest of the week. So what is that? Okay, that is clearly not a psychosomatic symptom. And I think this is where the clear distinction needs to happen, that people labeling all this as psychosomatic depression, there's no blood test, etc., etc. But what is this? That they do 1 hour of something and then they can't do the job for rest of the week. So I think it's quite critical, and I think all the dysautonomia research or all these unexplained illnesses need to focus their research on PEM and on the crash. And also emotional trigger as well. So those are the triggers which cause a crash. So again, this is there in textbooks. We don't need to go into the details, that you've got a sympathetic system, you've got a parasympathetic system, and your sympathetic system is more like the fight or flight response you get, puts up your heart rate, your blood pressure, you start sweating, and you respond to the threat. Whereas parasympathetic system is a system which relaxes you, and again, for different organs, so one has a secretory role and one has a contractile role, etc., etc. We don't need to go into the details, but what they do is they manage the kind of the equilibrium and the internal melee of the organs and the functioning, which is all automatic. So it's not under voluntary control, and it's just happening automatically. All the secretion of hormones and all the different functions which happen on an automatic basis is happening from the autonomic nervous system. So it's quite a key, essential system, isn't it? And again, we've got a neurologist here in the crowd, and neurologists, again, experts in central nervous system, peripheral nervous system, but there are not many actually who research into the autonomic nervous system. Any thoughts on that, Nick? Why would that be? Is there?
I guess it's just always been considered very specialist. Somewhere like Queen Square, we were very lucky to have an autonomic unit, and as you're kind of growing up as a consultant or as a doctor, you can always pass the problem on. But I don't know what it'd be like if you're in a district general hospital.
But then again, Nick, this is the only autonomic unit in the country.
Sure.
There's nowhere else. Like, for example, in Leeds, I go and say to neurologists, "Are you interested in this?" Nobody are. I think it's again because of probably the reliability of the tests, and how do you pick up structural damage. And there are some conditions where you can't demonstrate a structural damage. So we know that in brain injury you get PSH, you get sympathetic hyperactivity, and everyone knows that that's because of your central autonomic network is gone. You get that and you know how to manage it. You know that in spinal injury, you get autonomic dysreflexia, which is again damage of sympathetic nervous system, and you know how to manage it. But when it comes to other conditions, where it's not clear there's a structural damage, this is where the problem comes, where you have this, is it all psychosomatic or whether there's an autonomic, and I think for some reason, the people tend to stay away from that area, even though it is actually, it should be under neurology, isn't it?
Sure, but I think the point is it doesn't really get trained. It's not
Yes.
really part of the training.
Mm.
And I think your point about just not having a test where you can just request a test and it says,
Correct.
is it working, yes or no?
Mm.
Are you anemic? I'll do a blood test. Have you got brain tumour? I'll do a brain scan. It's easy.
It's easy, yeah.
With autonomics, you're going to have to engage your brain a bit more, because you have to be clear about what the clinical features are, what the question is, and then you've got to work out what the test is, and it's just...
And then what to do? Any thought? Yeah. Any thoughts on that?
What was said?
Sorry?
What was said?
Oh no. It's just about professionals not actually taking the autonomic nervous system seriously. Sort of, not being interested or driven by studying the autonomic nervous system.
Or not feeling confident.
Or feeling confident. Okay. Okay. Any questions so far? How many people have had training on autonomic nervous system, what it does, and how do you assess the autonomic nervous system in their respective disciplines at any point as a student? 5, only 5? Good, right, all right, okay then. So let's move on. So as I said, please feel free to interrupt and ask questions. We're all new to this area. So, so this is what I was saying. So, when there is a structural, central, or a peripheral injury, we all know that you get dysautonomia. In Parkinson's, ABI, spinal cord injury, diabetes, you get peripheral nerves affected, and you get autonomic neuropathy, and you know what the symptoms are. But the problem is that last box, where it's idiopathic, where all these other conditions sit, and actually they're very poorly understood. And I think, rather than saying poorly understood, I think the link between the autonomic nervous system and these conditions has not been well established. But if you look at, this is the key bit, if you look at these symptoms are actually seen in these conditions where there is structural damage to your autonomic nervous system. So it's a similar symptoms you're seeing here, but there is no structural damage. So I think it's very obvious, isn't it, to make a link and work out, well, without a structural damage, how could you get these symptoms? And then that will solve all that. Any guess from this crowd, from this audience, what's the prevalence of all these conditions put together in the general population? Sorry?
70?
70? Wow, that's a lot.
10%?
Yeah, it's around 10%, isn't it? So fibromyalgia is around 5 to 6, that's 1%, and long COVID is already 1 to 2%, so it's around 10%. So it's huge. What's the prevalence of these conditions put together? Parkinson's, ABI, spinal cord injury, and MSA put together. You've got more expertise, so I'll go with whatever you say. Probably 2%. Yeah. So why are we focusing? Well, this is quite a provocative question. Why are we focusing so much on this and completely ignoring this, calling it psychosomatic, and not interested in this area? How many of you get excited to see a patient of fibromyalgia or chronic fatigue in your clinic? There you go. So you've got 10% of the population lost their job because of the condition with disability. Now, we're not talking about morbidity and mortality. We're talking about DALY, disability adjusted life years. So here is a problem for the population with greater DALY problem than that, greater prevalence, at least 5 times more prevalence than that, but completely under-recognized, under-researched, and what's worst, it's like lack of belief. Nobody wants to see these patients, isn't it? My colleagues actually laugh at me, saying, well, how are you doing this clinic? Must be crazy. But then, what about the prevalence? Who's going to solve the problem for these patients? This has been going on for centuries, for decades. These patients have not been believed, and there's nothing happens, and they are disabled. As we said, Florence Nightingale herself, 20 years was in a bed, and we celebrate her, but what have we done for her illness? We have not found any answers yet. Okay, right.
Manoj, can I ask a question?
Oh, yes, sorry.
And because sort of listed them as one-off or sort of individual things, but certainly from that idiopathic group,
Yes.
it's probably interesting. A lot of those, you might see all of those syndromes together.
Yes.
And there's a lot of
True,
crossover. But
true.
then actually, as you go up, certainly if I was taking diabetes or some of the acquired brain injury, you then start to see some. There's a massive crossover of all.
There is. But I think the problem is here, as we said, as Nick was saying, the problem is there is no test. Whereas here you can demonstrate structural damage, isn't it? So it's very easy to say, okay, your central nervous system is affected. We know that autonomic centers are centrally, and your central autonomic nervous system is gone. But here, there are no answers. And then the solution is to leave it untouched. That's what we've done. We've left it untouched. Nobody is researching into these conditions. They do some disability work and all that stuff, but in terms of the pathophysiology, there's hardly any research. There's some I will show, which is really, very interesting research, but there's disproportion to the prevalence. So this is what I was saying to NIHR today. So I was saying, guys, you need to put out a dedicated call for these conditions. And they said, oh, what? Why should we put a dedicated call on this? We will give equal priority to everyone, and it's open competition. You all apply. Well, I'm saying, why are we investing so much? So is your investment in proportion to the prevalence in the population? You're clearly not. Why are we investing hundreds of millions in cancer, which affects 2% of the population, and you're not even spending 1/100th, we worked it out, 1/100th of research in these conditions where it's affecting this much of population? Oh, it's about death, it's about people's fear. But I said, no, population, quality of life is about disability. It's not about dying. It's about it's about how you live those years, whether you got quality or not. It's not about when you die. Well, why are we investing in 10 drugs to extend your life by 6 months? Why can't you put some of the money here, which can change the disability in these conditions? So there were no answers to that.
What did they say?
There were no answers. Oh, Manoj, you always go down this route. So it's a hard one.
There's an inherent problem in the way that everyone within healthcare works, and that we like to be sure.
Yes.
We like to sit there and say to
Yes.
ourselves, right, I'm going to
Yes.
get this game
Yes.
and that. And these things that you brought up, because there are no answers, very few people like sitting in clinic and saying, oh, I'm not sure.
Exactly. So then we should be investing more. We should be actually disproportionately investing in these conditions to actually bring out more research. So, it was staggering. The patients today were said 300 million in a year spent on cancer research, whereas for long COVID and ME/CFS, it is 6 million. And if you look at the prevalence, it's completely the opposite. So it's like, what are we doing here? So anyway, I don't think anything will change, but it's good to make these points and make people think. I'm sure all of them on their train back, they will be thinking, well, actually, it is a valid point. We need to do something about these conditions. And we've got facts, in all our research, we've got data which is demonstrating the incapacity. So in long COVID research, the locomotion we did, we estimated the impact on health economics to be 12 billion a year, far ahead of anything else, of diabetes, of stroke, of brain injury, far ahead. So we've demonstrated the economic impact because people have lost their jobs. So then you can work out what is the health economic argument. So we've done all that. So I don't know what else we can do to convince NIHR and funding. I mean, it's good that, I mean, they had a dedicated event today for it and all the researchers came. So I think it's a start. We'll see where it goes. But maybe these are the problems we face. Because not to forget, this is all the workforce. So just in NHS, as I said, in our trust, we've lost 50 members of staff for these illnesses. Okay, so that wouldn't be the same for this, right? And this is within a span of 2 years. Okay, so I hope.
I mean, since you're
Oh,
comments
sorry.
as you go.
Yes, of course.
I mean, the answer is, I mean, the barrier at the moment is, and presumably this is what you're going to go on and talk about, you don't have a mechanism.
Yes.
You don't have a mechanism, you can't come up with a rational therapy, which unless we're just talking about supporting people, which is, that's a perfectly reasonable thing
Yeah.
to do, but you're not
Yeah,
talking about that.
we need
You're talking
mechanisms.
about
We need mechanisms research.
rational therapies based on mechanistic approaches, and so I guess NIHR or these other people are going, cancer is very straightforward. This receptor's gone
Yes,
wrong, this molecule's
yes,
gone wrong.
yes.
It's very clear in their mind. I'd say it's pretty much the same with all rehabilitation.
Mm.
These people they go, well, I don't understand what the mechanism is, it's too
Mm.
vague, isn't it just being nice to people and being supportive? So if you can go on and show us potential mechanisms, then you've got therapeutic targets,
No, but
which
Nick,
you can then start to do research.
that's true, Nick, but I haven't done that mechanism research. All our research has been demonstrating the economic impact, and as I told about, PEM and the link and all that, but I have not done the autoantibody research of what happens, because we know, I'll come on to it. I mean, we've got antibodies against the autonomic nervous system, we've got adrenergic autoantibodies and all that, but that needs more work. There are papers trickling in from here and there outside UK saying, oh, we found this antibody, and you give them immunoglobulins and you can fix them, but that needs more work, isn't it? You need, MRC was in the room, but they were hesitant to put out a dedicated call to say, because otherwise, if I'm putting an application to study these biomarkers, and then there's an oncologist applying to say, well, I will solve this cancer, I have no chance in a call, isn't it? If it's an open call for everyone.
I don't know, that's up to them.
And the panel. So the problem is the panel don't trust as well. I mean, there's still how many skeptics in this room about all these conditions. You might still be thinking, well, this guy is telling all this, but this is just a crazy lot. How many people are thinking that? So it's the same with panels. Panels don't buy the argument as well that there's something physiological which can be identified and targeted. They don't buy that, and we are at the mercy of the panel, isn't it? And panel are just people like us.
Sure, I'm playing into all of my own paranoia. About my own work. I say exactly the same thing about things I'm interested in. Maybe everybody says that.
Yeah, okay, right. So, so we'll just move on to a bit more sort of an area where I'm doing all this work, and all we've done is what we did today in Royal College of Physicians is to bring all this together. So we are saying, look, long COVID has not happened for the first time, okay? It's happened after SARS, it's happened after MERS. All these other conditions, you talk about Ebola, chikungunya, all of these outbreaks have had a tail of people with persistent symptoms. So there is a pattern here that all these viral infections, or actually non-viral as well, as I have listed there, and we talk about Florence Nightingale, that was brucellosis, so it's not a viral infection. So these infections, they are leading to these long-term symptoms in select patients who are vulnerable. Now that is where the genetics come in. Maybe some people are more susceptible to get these long-term symptoms. But then what happens is, when you put all this together, suddenly you're totally talking about a new field of medicine. So today one of the discussions was, post-infectious long-term symptoms must be a totally new field of medicine which needs to be properly recognized and properly funded. Because if you put all this together, and now ME/CFS is not even in the list, we've just put the kind of, the viral infections we know, because ME/CFS again is contested. People also think there are other theories to explain its thing. So when you add all that, it completely becomes a very long list. And what is key here is there will be another pandemic. Every 10 years there's a pandemic. SARS, MERS, COVID, 10 years gap, you will have another one. And then that shock, when I said that, people were shocked. Are we going to have, there is going to be another pandemic, and there will be a tail to that pandemic as well. So if you're not going to recognize and do something about it now, it'll be the same situation in the next pandemic. You'll have lots of people going on with these symptoms, and you'll be clueless because you have no history, you've got no memory of all the work which has gone on till now. So this is why we need to recognize this. I mean, BSPRM, we've set up an international post-infectious society now, and it's got a lot of members, and we are hoping that becomes, that will drive this aim to establish this as a new field of medicine because of just, the high prevalence in the population. And if not anything, it's just going to become bigger and bigger with time, with all these outbreaks. By the way, also influenza and all the kind of hospital-acquired pneumonia infections you have, they also struggle with this. And that work has not been properly done. With all the infections that you get and the HAPs you get, if you follow them up, again, there will be 5 to 10% of these patients long-term who will have persistent symptoms, and they're struggling to make a full recovery. So that needs adding on this list as well, even though it's not on this list. What has happened in COVID is because of the volume of patients, millions affected worldwide, suddenly people realize that, okay, there is this another cohort, millions of people with these persistent symptoms, and hence it's got its recognition. But if you think about any hospital where people got admitted with sepsis, infection, and if you follow them longitudinally, definitely 5 to 10% of them will have these long-term symptoms, will have chronic fatigue, which is becoming a long-term condition. So that doesn't get recognized because, well, we're all busy, isn't it? We don't actually track them longitudinally and look at what persistent symptoms they have. And even if they have, we don't link that to the infection. We don't do that. But in COVID, it's just happened because of, it was one event and so many people were affected. So I think, Nick is expecting to see a lot of physiology. Now, this is what is our understanding, that there are some people who are genetically predisposed, and these people have the receptors which will lead to persistent inflammation. And in the process of inflammation, there is this cytokine cascade, and also there is autoantibodies which are actually affecting your organs and leading on to cognitive deficits, fatigue, and as I said, the autonomic nervous system. There is definitely neurotropism, that the virus actually itself and the cytokines have got this kind of affinity for the nervous system and lead to central sensitization. So something which I've not included here, we did a very interesting piece of work, actually maybe I should have included here, that what we did is people who had COVID infection, we asked people for any chronic pain symptoms they've had in the past, and we selected people who had no history of any pain symptoms or chronic widespread pain symptoms in the past. We selected them. They all are patients with long COVID with no pre-existing illness. We followed them up for 18 months, and we did serially. We did cytokine profiles, we did, tracking their pain pattern, and guess what? At 18 months, all of them met the criteria of fibromyalgia, of chronic widespread pain. No pain at all previously. We've nicely demonstrated that initially there is a cytokine like erase, all your cytokines are raised, IL-1, IL-6, TNF, everything is raised, and with time, so we had baseline 6 months, 12 months, 18 months. By 12 months, all your cytokines have come back to normal. But then when you do QST, which we also did longitudinally, the marker for central sensitization, where you get the spike in the response to pressure, that response was sustained at 18 months. So that is a marker of central sensitization on the quantitative sensory testing. So that's a nice demonstration of, the inflammation is gone, but the inflammation has done a damage to your nervous system, which is leading to this chronic widespread pain. And also that the clinical criteria for fibromyalgia has been made. So then you make the connection now that all these patients with fibromyalgia, did they have a severe infection which led to this? And you don't make that connection because you didn't have that critical mass. So there are some pointers I think we are getting for both chronic fatigue and for fibromyalgia from studying COVID, and you know, this is, we talked about this, that it's that inflammation and it's that autoantibody which has got this affinity for the nervous system and causing the damage, not a structural damage, but damage with the transmission, the neurotransmission, and you know, the function of the system. So, so we've written numerous articles. I particularly like this one because I think this was a time where we were, you know, understanding dysautonomia better, and we said, you know, you need a you need more awareness of this given the burden of these patients at the moment. So it's a while ago, I think, this one, I think 2022. Okay, so again, testing. So there are lots of ways you can do testing. So you can do outcome measures, patient-reported outcome measures. There's something called, I've not put COMPASS there, so COMPASS 31 is the gold standard subjective measure. So it will go through, if you remember the slide where we had these different systems and we had all the symptoms, what they get. So patients get asked about those symptoms in the last, COMPASS is last week. Then you have to rate them, and then there is a score. So it's out of 100, and if you get more than 30, then yes, you've got a problem with your autonomic nervous system. But that has been there for, you know, ages. And it's always challenged that if you take any condition, chronic condition, and you apply COMPASS, you might meet it. So this is something new, which is the testing, the NASA lean test. Now, tilt table testing has always been around, where it's a passive test. People go, when you suspect dysautonomia, let's say Parkinson's and other conditions, then they go on a tilt table, you eliminate the gravity, you tilt the table, and you look at the changes in your blood pressure and heart rate. So that is how you test for, you know, your manifestations of your autonomic nervous system, which we know will drive the heart rate, the blood pressure. So that's the way it was done. Then lean test was introduced a while ago, where they were testing, I think it gets the word NASA because of people who want to go on space. They used to do this test to see whether their autonomic nervous system is functioning okay. So people lie down, and then you make them stand up, and then for 10, so you make them lie down, and then you measure their heart rate, your blood pressure, and whether they have any symptoms. So the patient needs to be rested for 2 to 5 minutes. I must say this is very important. You just can't make them lie down and straight away check, because they have to be properly relaxed for at least 2 minutes. Then you make them stand up, and then you immediately measure their heart rate, blood pressure, and you measure till 10 minutes. Keep going with measuring your, I don't know why this bar is coming here. Anyway, and then you keep measuring your heart rate, blood pressure, and any symptoms. And I think that is the key, where you ask people to ask them to report what symptoms do they have once they stand up, because if they have no symptoms, I don't think it has got much value in terms of how much fluctuations you see. I unfortunately haven't got many slides on this, what is abnormal. So I can just talk it through that when they stand up, and if your blood pressure systolic drops more than 20, then as you all know, that is orthostatic hypotension, and postural tachycardia, POTS, is when your heart rate goes up by more than 30 without a drop in blood pressure when you stand. And for adolescents, it's 40. For children and adolescents, it's 40, and for adults, it is 30. So the heart rate going up, then it's positive. Or if the blood pressure systolic drops by 10, or if the diastolic drops by 10, systolic drops by 20, or diastolic drops by 10, then it is orthostatic hypotension. So both are forms of dysautonomia, because when you stand up, you know, initially there is a very short, for seconds, there is drop in your blood pressure and your heart rate goes up, but within seconds it's normalized, within seconds. So within a minute, that's why we put on standing and then 1 minute. In a healthy individual, by 1 minute, everything is normalized. You've got your normal blood pressure, normal heart rate. But you will see that in these patients, it is clearly abnormal. It goes on up to 10 minutes. You know, your heart rate is all over the place. Your blood pressure is all over the place. We've seen systolic drop of more than 50. We've seen heart rate rise more than, almost doubling from 80 to like 160. And they're all symptomatic. So what's happening, the understanding is, because the autonomic nervous system, and it's very similar to autonomic dysreflexia or any other, in Parkinson's you get the autonomic failure. It's very similar to that when you stand up, your venous return is not there because you don't have that tone in your vasculature. So there is pooling of blood. Once there is pooling of blood, your blood pressure is falling. The heart is saying, well, where's the blood? So the heart rate is going up, and that is your response. But then it's not correcting because the venous return is not there. It's as simple as that. But there are different grades to this. And I think this is how one can test for autonomic dysfunction. So as I said, we have focused a lot of research on taking this test to various conditions. So we've been doing this in long COVID, now we're doing it in ME/CFS. We've taken it to fibromyalgia, and guess what? So there was no link between NASA lean test and fibromyalgia, and what we've now done is we are finding that the abnormality rate is more than 60%. So that's huge, and those papers will come out soon, that when you test them, they are all abnormal on a NASA lean test.
Manoj, what is it
Yes.
in a normal population? Does
Yes,
comparison?
yes, coming to that. So this is the constant criticism we get. Oh, have you tested normal people? It's always abnormal in normal people. So we've done that too. So that's what we've done for the last 5 years, by the way. Okay, anyway. So, this is not moving for some reason. Yeah, so this is the project I talked about, which got me into this field. This was a 3.4 million grant by NIHR. It was across 10 sites. It was more like health services research, more around recognition, setting up clinics, setting up staff, and we've done all that for 3 years with that grant. And this was actually the paper which came out of that project, that we got all the clinics to do the NASA lean test. And this exactly was the question, to say, well, what about normal healthy volunteers? So if you don't have normal healthy volunteers, how do you know what is normal and what is abnormal? So this study was done with healthy volunteers. So small numbers, but nevertheless, those are healthy volunteers with no issues. They might have had COVID, but they made a full recovery, and these are the patients with long COVID, and you can see the difference, okay? So these are the people, so this is the heart rate response to what happens when they stand. This is healthy volunteers. This line is also actually a group of long COVID patients who do not actually have orthostatic intolerance on standing. That is also important, isn't it? Because it's a heterogeneous group. Not everyone will get that response, but clearly there is that group of people who are way different from how healthy volunteers' heart rate is responding on standing. 10 minutes. Somebody said, well, that's a small number. It's hard to do this kind of research. And then we said, okay, we'll get medical students to do some more research on, that was again that paper which basically showed it is clearly different from healthy volunteers. Sorry.
Can I ask, I don't know if it's controversial, but do you need to match your controls in terms of activity and stuff?
Yes, I mean, we did matching as best as we could in terms of, previous activity levels and comorbidities and things. Are you hinting at deconditioning?
Yeah.
Yeah, I think it's going to be hard, isn't it? These patients, many of them had COVID and made a full recovery. I get asked deconditioning quite a lot. What we did now is we picked up inpatients, actually in a stroke rehab ward, 50 patients in a stroke rehab ward. Now you could argue many of them might have autonomic dysfunction, but we were very clear that we were doing subjective testing for the things I talked about with compass testing and all, and if they're not reporting anything, and we know that they've been there for months in a hospital bed, and we did lean testing on them, and we didn't pick up any abnormality. So I do not think that this is a deconditioning problem. Of course, we need to do more work, more data, but we have looked into deconditioned patients, and we don't get that response. Is all I can say on a small patient group. Sorry.
I'm not quite sure I understand, Scott. Is it telling us that long COVID patients are different from healthy volunteers?
Yes.
Some of them are and some of them aren't.
Yes, on the lean test.
Right, but there's only one of the long COVID subgroups is different.
Yes, exactly.
But they're different on the thing that you're actually plotting on the y-axis, so it's a self-fulfilling prophecy. So your top line,
Yes,
you're saying you're looking at the change in the heart rate, which is what POTS is, right?
correct.
So you're saying, do people with POTS have POTS? Yes. Do people without POTS not have POTS? No, they don't have it.
But these people did not have
So
POTS
I'm-
before. So
Right,
these
why-
patients were.
But why, so what question are you trying to answer with this graph?
So the question we're trying to answer is, in long COVID, if you do the lean test,
Yeah?
your response is, in some patients, is different from what you get in healthy volunteers.
But why haven't you plotted all of the long COVID patients?
Ah, okay. I mean, if you combine that and that, you'd probably get a line over there or something.
Yeah.
But here, what we're trying to demonstrate is, there is a group of patients who are clearly abnormal, and there is a group of patients actually who are near normal. So rather than combining both and then say, well, they will still be different.
It doesn't mean that the POTS got anything to do with the long COVID. I mean, you may as well, that could be people with long COVID and migraine, and people without migraine, and then you've got a migraine score on the.
Okay,
y-axis.
true. And the other issue is, because POTS has got a diagnostic criteria that you have to meet a threshold of increase by 30. So this is why it got separated into a POTS group. So the average, I can tell you the figures. So the average change in heart rate in these patients was around 80, I think it's 18, right? Whereas the average change here is less than 10. Whereas the average change in long COVID patients is different. But these are the patients who met the criteria of POTS. That's why you've got a separate graph. I mean, you're right, you could just combine everything and say, okay, normal healthy volunteers, the change in heart rate was 8 or 10, and then it was 18 in, it's still different, it's still abnormal. How do we explain that?
I'm not saying it's not abnormal, but I'm just saying it's a
Why the graph has been put this way? Yeah, I should ask my statistician.
Have you diagnosed POTS based on their NASA lean test result?
Yes,
And
yes.
so that's why you can see
Yes.
that there's that difference. between
exactly,
the two groups.
exactly. And this is again quite contentious, and that's why I was keen to have people from the Autonomic Unit. They will challenge this and say, oh, they need to have a tilt test. But there is research coming out which shows that they are equivalent. So they've looked at people, they've done the 10-minute test, they've done the tilt table test. The diagnosis they are making based on that is the same as the diagnosis. So this is very powerful because you don't need tilt tabling. You can do it in a clinic setting. Anybody can do it anywhere in the world now. You do a 10-minute test and look at its abnormality. But again, the key thing is symptoms. You know, if your patients don't have symptoms, then you don't diagnose them with any of the dysautonomia syndromes. You're still skeptical, but that's good. But that's how everyone is. That's how everyone is.
Graph, you can say, look, you have the top line, which is people with POTS, and then you've got the bottom line, which is people without POTS.
Yes.
But that's not that interesting, and we know that already. It doesn't have to involve long COVID at all, that graph.
True, but the POTS is because of the COVID.
So then depending on the proportion,
Yeah,
is it?
they didn't have POTS before, these patients, because we've got data. So the outcome, the C19 virus scale which we've developed, which is now used in all this population, it clearly captures patients' symptoms before and after.
I mean, you publish this, it doesn't really matter, but I would have just plotted the long COVID people versus the healthy volunteers.
No, that is true. I mean, the graph
And then done
is
a sub.
Sorry, I
Is-
also have a question.
oh yes,
So
yeah.
among stroke patients.
This is good, come on.
Among
Get all the
stroke
questions.
patients, and if they are symptomatic, would you do a POTS and then do a nasal leak
Yes.
and then diagnose them with a POTS?
Yes, absolutely. So if they have no symptoms, then what are they doing in the clinic? Yeah, they would come with symptoms. But the key thing is, for a lean test to be positive, they need to have new symptoms. So you make the patient lie down, the patient is settled, and you ask, have you got any symptoms? And then if they still have symptoms, it's still okay. When you make them stand, you're looking for new symptoms. So if the patient is already dizzy and having palpitations when they're lying down, then, well, okay, but you need to see the change and whether there are any new symptoms. And also to say many of these patients we have to discontinue midway because they're so dizzy. And that's why it's called the lean test as opposed to the stand test, because they're leaning against the wall so that they just don't fall in the clinic. Oh, yeah. Go on then.
Tying up in the next few minutes as well. We're coming to
Oh, is it?
as well.
Oh, right. Oh, I've got more. I've got a lot. Well, I said half an hour and you said keep going for another.
Is there a difference, so do the two long COVID groups, ones with or without POS, do they have difference in any other symptoms?
Well, no. I mean, it's just that they don't meet the criteria based on, because your criteria is just based on your changes in heart rate.
Sure, but I just want whether if
I've
some kind of long
Yeah,
COVID
not looked at, but I will look into that, Nick. Sorry, only 5 minutes. Oh dear, I've got a lot.
So we can, I mean, yeah.
I've got a lot. Okay, we can push through. Well, anyway, I was going to say the paper got an award recently, so thank you for that. And I heard that there were a lot of papers submitted, so clearly the paper's done well, isn't it? Okay, so this is maybe this will help, okay? So this is phenomenal. Medical students said, okay, we will go and we will do the lean test on 100 patients who've got no symptoms, who've got no dysautonomia, and this is what we see, okay? So when you stand, your heart rate? Yeah, your heart rate goes up on an average. This is 100 patients to about 7, and then it slowly drops down. What happens? This is very interesting. What happens to your blood pressure, your systolic? When you stand, it goes up by an average of 7. Your diastolic goes up by 4, and then it tails down. Every long COVID patient I see, blood pressure invariably drops. I've never seen a blood pressure rise. Come on, I mean, we don't need anything better than this, you know. There is a problem that the blood pressure is going down and your heart rate has got an exaggerated response. I mean, on average, is somewhere from 18, as I said, to about, as I said, even doubling to 160. So it doubles, the increases by 80. That is the response we get in these patients when they stand. And this is 100 healthy volunteers. Any comments on that, Nick? Okay. Anyway, so I mean, this is the link I was going to demonstrate with the UCL team, and we've done a lot of work with Chris Mathias. And so during the pandemic, he also had the same issue that, you know, because of all the isolation stuff, you can't get people to tilt table. So actually, he came up with something called AAP, which is basically there are triggers to dysautonomia. There is the food intake, and there is exercise, and there is the standing. So he came up with a protocol, which is basically mini lean test for 3 minutes, but with triggers. So after breakfast, what happens to your blood pressure and heart rate? What happens after exertion? What happens after standing? But then I said, well, I want to be the first author on it, and I wrote up the paper, so it comes up against me rather than him. So, well, you know, where does it fit in with, you know, with this? You know, you can refer to that paper. There is a role for AAP when compared to the NASA lean test, and because that is more dynamic, you can do it repeatedly, and you can do it with other stresses, because don't forget, it's just not the position, you've got other stresses as well, you know, exertion, food, emotion, things like that. Okay, look at that response. Okay, so there you go. So this patient, hopefully we've removed all the identifiers. That is a heart rate. So this is on AAP, so it's like mini lean tests, and see what happens to the heart rate 3 minutes of standing. Okay, that happens after breakfast. And look at this, after exertion, minimal exertion, up and down the stairs, gone up to 161. Will our heart rate go up to 161 if you go up and down stairs? Not sure. And this is after lunch. You had lunch, you have lunch, and then you do a 3-minute lean test. Will your heart rate go up by 1 to 138? And what is this? This is doing laundry, carrying it upstairs, something like that, you know. So look at the response. Anyway, we need to rush. So how do you manage? So again, this is a talk on its own. You know, you take a history, you do some tests, you do the NASA lean test. If it's abnormal, I don't bother with sending them anywhere. So I hardly refer anyone to tilt testing these days. Once you have a diagnosis, then you manage, as I said, it's all about pooling of blood. So this is again contested, how does oral fluids, does it say intravascular, does it help? We are doing some more work in building an evidence base, but this is for centuries in textbooks. You will find any book of POTS you pick up, they will say, do fluids, do salt. But really, salt and fluid, how long will it stay intravascular? So we are not sure about the evidence, and we are looking at evidence for it. And then, as I said, you diagnose OH, POTS, and we use all of this quite a lot. You want to suppress your heart rate, you use ivabradine. If you want to build up your blood pressure, you use hydrocortisone, you do midodrine, and all these go hand in hand, all these investigations. Okay, so pacing. So we talked about the PEM, and this is where pacing comes. So I think the key, as I understand and as I keep telling my patients, is to avoid those crashes and stay within your energy limit. Don't allow your autonomic nervous system, your whatever, if it's an inflammatory immune system, to crash. So stay within your energy limits and see whether that helps stabilize your condition. And that's the study we did. And that is actually, in fact, we were lucky that WHO was knocking on our door. We wrote that for WHO. It's part of the WHO's protocol now and how to pace. So basically what it is when you're recovering from any viral illness, or now you can apply it to any infection, you've got to pace appropriately. You can't just go straight to the previous job you're doing, because you will crash. That's the nature of the condition. So you pace until you feel that you can expand a little bit more. And these are these different phases that, you start doing it in a phased manner. If you do not crash, if you're crashing, that means you're overdoing it and you've not reached the threshold to step up. So then you hold yourself back. And then there's this whole controversy on graded exercise versus pacing. And again, that's a whole talk on its own. But pacing is now the gold standard treatment for anyone with post-exertional malaise and with fatigue. And again, this study, we can skip that. What we found very nice, that if they probably do pacing, slowly actually their activity goes up, and you can see the PEM episodes. So when you get that crash, it's called a PEM episode. So the number of PEM episodes actually nicely come down. So this is a classic demonstration that pacing works. So if the theory is, if in the first 6 months after the pandemic, if all these people had adequately paced, they shouldn't have got long COVID. But then we can't prove it now, right? It's too late. Maybe that's for the next pandemic to do. So you can see nicely the PESI episodes coming down if you pace, the results there, EQ5D going up. We are all interested in EQ5D, isn't it? EQ5D is such an insensitive measure that even EQ5D is showing that people are changing. But this was done, in sort of relatively 12 months in long COVID. If you leave it longer, it becomes a long-term condition and you can't treat. So I think the point I'm trying to make is you need to apply this to any other patient as well who's got chronic fatigue, who's got PEM or PESE. And if we think that they've got dysautonomia, you either tilt test them, or you can do your lean test. If they're abnormal, if they've got crashes, this is the treatment. I think, pace them properly. If they're getting crashes, they're not ready to step up. And I think this is the key. This is very key, because what's happened with all the long COVID patients is they were going to all the therapists and they were saying, push, 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 go to the gym, break it. This is what we do with other MSK conditions. You've got to break the cycle. It's a vicious cycle. This is completely opposite. This is a vicious cycle. You stay in the cycle unless you're ready to step up. It's a complete opposite phenomenon, and I think that's what we need to do for this condition. And I think that is because of the involvement of the autonomic nervous system. Okay, so technology, we've done heart rate variability, so we know about the variation. So you can show a patient how their heart rate is changing. So when they get tachycardia, actually the heart rate variability is coming down, so it's low HRV. So you can display that for the patient on an app, and you can show them how their HRV is behaving, and you can give them breathing techniques and other lifestyle measures to change their HRV. So this is the HEARTLOC study we did, where you put the polar strap, and that gives you a display of your HRV, and then you do the breathing technique, and you can try to increase. So what you're trying to do is you push your parasympathetic nervous system and the vagal tone. There was going to be a little demonstration. Let's see whether this runs. Yeah, it's just, you can just see the patient is doing some breathing techniques, and it will show a display of the HRV in a minute. HRV is normally in the 50s, so if you do our HRV, it should be around the 50s, and if it's low, then there is some kind of dysautonomia going on. So that can be displayed to the patient, and then you can do those techniques. You can see it's 47, and then you ask them to do the deep breathing, because when you do the deep diaphragmatic breathing, you're stimulating your parasympathetic system. You can see how low it goes, and then once they do it, then it starts pushing. I mean, because of want of time, I think I'll skip, but you can see that then slowly, gradually, once they start doing it, your HRV starts going up, and then you demonstrate that to them. Then they understand the concept, what they need to do so that their HRV stays up. So now there are apps and there's visible technology and things like that they wear, and they can constantly monitor the fluctuations in their HRV. There you go. So it's come up now. So once they do the technique, it comes up. So let's move on. And the patients did well, significant change in all the measures. Okay, so new research. I mean, I think we touched on this, and there is some fascinating research out there. They're looking at adrenergic muscarinic receptors for the autonomic nervous system, and they've identified some autoantibodies which actually are acting on the autonomic nervous system. So that is possibly the explanation, the best we can get. Why are these patients having dysautonomia without having a structural damage? We know that virus in itself has got the kind of, the neurotropism for the nervous system. So if it is attacking, we've shown that it is affecting your central nervous system. Why should it spare the autonomic nervous system? So this is new research where they actually took the IgG and they injected into the mice, and the mice started having all the symptoms of fatigue and pain, and then once it's out of the system, then it was becoming normal. And then there are new treatments on immunoadsorption, okay, so where you run the patient, you take the blood and you run it through a system where you extract these autoantibodies and inject it back to the patient, and symptoms are better. This is in Lancet, by the way, so it is rigorous and it is good research, and this is the future, I think, for all those conditions. So some work is coming out, and I'm really excited about this. I'd like to do all this stuff if there's good funding. That we can give these treatments, whether it's IgG or immunoadsorption or the JAK inhibitors, anything which will control this cascade and help these patients. So to summarize, I think we need better screening. I think we need better awareness of dysautonomia, not only in post-viral conditions, in all chronic conditions, I would say. I think even though it might sound very kind of not groundbreaking research, I think this is key, because this can take the treatment to every clinic and to people's homes, that there are easy ways of diagnosing dysautonomia, and we obviously need more mechanisms, we need more biomarkers research, and we need more interventions. And this immunomodulation, I think, is the space to watch for the next 10 years as how we can change. It could be a game changer. We need more specialist autonomic medicine. I mean, we talked about 10%, and we've got one autonomic unit in your center in the country, whereas in Europe there are quite a lot. I mean, per patient population, I think France has got 3, 4. Other countries have more, definitely much more than the UK. So more work to be done there. Yeah, thank you. I mean, we've been grateful to all our funders and all the awards we got for all the work we've been doing. Thank you so much.
Thank you so much, Manoj. Okay, so if anyone has any burning questions, we can probably have one or two. Otherwise, I'm sure we can bother Manoj over a glass of wine outside. So, no? Yes? Go on. Okay. Will, and then Nick, and then we get some wine.
Do you see similarities, or what do you think the relationship is between these post-COVID symptoms and something like post-stroke fatigue?
Yes. Well, I think it's a completely open area to be researched, and I think this is why the history taking needs to be critical, because if stroke is damage to the brain, so what's happening to the central autonomic nervous system? It is damaged, isn't it? So why are we not actually testing these people in history for, well, have you got PEM? Have you got PESE? Or just lean test everyone. You will find what's abnormal, right? And if there is got abnormality, and if the patient has got fatigue, I think that patient needs proper pacing. Otherwise, no, if you keep pushing this patient, you're not going to get proper outcomes. I think it's a completely open area to research.
Do you think, I'm just interested in what you're saying about pacing at the end and people pushing themselves, etc. Obviously, post-COVID, there were a lot of healthcare workers that had developed long COVID syndrome. Is there any relation in terms of what activity levels are like before infection that means you're more likely then to get that pen and fatigue, i.e. if you're more active and that's been your way of life and that's how you want to deal with it, are you more at risk of that?
Yeah,
Is there no link?
yeah, no, it's very interesting. Well, all the patients we found, they've been like kind of very busy, high achievers, working on the edge, having very productive lives, fast-paced life, and then they get this, and then they get affected. Whether that makes them more susceptible, I don't know. But it is clear that only some people are prone to it. So there must be a genetic link. So now there's a study called Decode-ME who have identified some genetic markers for people with ME/CFS, and they are planning to do that with long COVID as well. So I think genetic link, more than physical activity stuff. I would like to think I'm very active. I've got COVID 3 times, but I haven't got long COVID, so I don't know.
Okay, so thank you again for an absolutely fascinating talk, and please everyone join us afterwards in the reception area. Thank you.
Thank you.